Alright, you guys, welcome back to the next lesson in our 6-part series covering the endocrine system. And in this lesson, we're going to be covering the differences between DI and SIADH. And for those of you who don't know me, my name is Eddie Watson, and I'll be presenting this lesson for you. Before we begin, if this is your first time to our channel and watching one of our videos, and you'd be interested in more in-depth critical care content such as this, then we invite you to subscribe to our channel below. Please make sure you hit that notification bell and select all notifications. This way you'll be notified as soon as the new lessons become available to you guys. I truly value the subscriptions, the likes, and the comments that you guys leave. They really go a long way to help support this channel and videos like this. And so for that, I do want to thank you guys. Alright, so like I said, in this lesson, we're going to be talking about the differences between DI and SIADH. And so in order to understand both of these, you need to understand that they're both disorders that have to do with our antidiuretic hormone. And we'll get into talk about what exactly is going on with each of these related to the antidiuretic hormone, but it's important to know that these are the two most common disorders of ADH that you're going to see within the ICU. So before we begin talking about these two, let's start out and talk about the pathophysiology of antidiuretic hormone. Now, we did talk about some of this in the very first lesson in this series, which I'm going to link to up above, but I do want to refresh on that and go a little bit deeper to give you an understanding of what's happening with this hormone. So as you can see, we have a slice of the brain here, and I went ahead and labeled two key parts, our hypothalamus pretty much in the middle there, and the pituitary gland, which is that pea-sized gland that kind of hangs off the bottom there. And so what happens is we actually have ADH that's produced in the hypothalamus, and it's sent down and stored in the pituitary gland. From there, as it's needed, the pituitary gland is the gland that actually will secrete this hormone. Now, as a quick refresher to that first lesson, if you remember, we have both the anterior and the posterior pituitary gland, and in the comments below, let us know if you remember which one it is that actually secretes the ADH. And so, like I said, the ADH is secreted into the bloodstream. From there, it's going to work its way down to our kidneys, which is where it's going to have its primary effect. And it actually has this effect on the distal collecting tubes of the kidneys. And if we think about the name, it's the antidiuretic. So what it's going to do is it's going to decrease the water excretion and really concentrate the urine, and that's the goal of ADH. By decreasing our urine output, we're also going to be increasing our hemodilution. So we're going to be conserving water from our urine and keeping it within our body. And the way that this regulatory system works is we actually have osmoreceptors here in the hypothalamus. And what they do is they respond to changes in osmolality, our blood osmolality. And so if we see an increase in that osmolality, it means we have more concentrated blood. And so even an increase of 2% in this osmolality will trigger the hypothalamus to tell the pituitary gland to release ADH. This then goes down to those distal collecting tubules in the kidneys, conserves that water from the urine, and helps to dilute out our blood. And so really this change in osmolality is what's going to really regulate the release of ADH. But we also have non-osmotic factors which are going to trigger the release of ADH as well. Things such as a decrease in our blood pressure, because now again we want to retain that water in order to provide more volume in our blood, helping to give us a better blood pressure. And we also see things like our stress response can also cause a release of antidiuretic hormone. Really kind of goes along with that adrenergic response that we typically will see in that fight or flight. Now, it's also important to know that if we see high concentrations of ADH, particularly we'll see this in our exogenous administration of ADH, such as vasopressin, that at this point, in addition to the antidiuretic function, it also can act as a potent vasopressor and can promote platelet aggregation. So in these high doses, there are these additional effects that we're going to expect to see, which might not be what we want necessarily. All right, so that's our quick rundown of antidiuretic hormone and our quick pathophysiology of how this hormone and this feedback mechanism work. So now let's move on and start to talk about diabetes insipidus, which is what we commonly refer to as DI. Now for DI, this is going to be the result of either insufficient or an insensitivity to ADH. So either we don't have enough ADH or our body is just not sensitive enough to the ADH to get the effects that we want. And so again, since ADH prevents our diuresis, if we don't have enough of it or we're not responding to it, that this is going to lead to an inability to dilute our urine and ultimately a volume loss. And this is the big problem that we see in DI, and this can really complicate the course for our patients in the ICU because it can cause this acute, life-threatening fluid and electrolyte disturbance on top of whatever else is going on with them. And so now in talking about DI, there's really 3 types of DI that we're going to find. The first is going to be what we call neurogenic. And this essentially means that it's hypothalamic or central. And so what's happening here is we have some sort of damage to either the hypothalamus or the pituitary gland. And this damage is causing an insufficient either creation of ADH or release of ADH. And so what this means is we're either not going to get ADH or have an insufficient amount of this ADH going to the kidneys to even attempt to concentrate that urine and preserve that volume loss. And as a result, this can actually lead to pretty significant urine output and volume loss. And some of the causes that can lead our patients into this neurogenic DI are going to be things like either trauma or brain surgery. Tumors can also cause this. Also things like strokes and aneurysms, autoimmune disorders, infections. And this would be things like TB, syphilis, or any sort of CNS infection can have this effect as well. Or it can even be an idiopathic cause. But I do want to point out that in the cases of trauma and brain surgery, that DI is typically not going to present itself for at least 24 to 72 hours. And so what's happening is as a result of the trauma or surgery, we're either going to have some sort of localized or general cerebral edema, which is going to cause pressure on the hypothalamus. And this is going to cause to a decrease in the production and transport of ADH to the posterior pituitary. Now, the posterior pituitary normally has stores of ADH, and so as time goes on, it's going to continue to release ADH from the stores that it has, but those stores are not going to be replenished because the hypothalamus is no longer creating that ADH. And so this is why we see it take some time for this DI to present itself. And really depending on the location of the damage that we have, this could lead to a permanent DI, but most cases are transient and resolve once we have resolution of this edema. All right, for the second type of DI is something that we call nephrogenic. And so this is going to be dealing peripherally down here in the kidneys. And this is going to be the result of inadequate response of the kidneys to ADH. And this inadequate response can either be from some sort of structural changes or some sort of functional changes with those receptor sites. And typically our nephrogenic is going to be less dramatic than what we see in our neurogenic DI, and it's really fairly uncommon for you to see this. And some of our causes for this are going to be our renal diseases, our renal disorders, possibly renal tumors, as well as nephrotoxic drugs. So again, just to think about this, here we're having a problem at the level of the kidney where we're just not going to be responding appropriately to the ADH. The ADH is going to be there and be present, but our kidneys are not going to be responding to it, again leading to that lack of an ability to concentrate our urine. All right, and the third and final type of DI that we're going to talk about is something that we call dipsogenic. You'll sometimes hear this referred to as either secondary DI or a primary polydipsia. And this one is going to be the result of excessive intake either of oral water or IV fluids. And so what happens here is because of all this intake, this is going to suppress the release of ADH, causing this polyuria. And usually this is going to be the result of some psychogenic cause. So typically we'll see this in patients with a history of either psychosis, hysteria, or depression. And so no matter which one of these types we look at, the end result is that we either don't have enough ADH or our kidneys are just not responding to that ADH, leading to an inability of our kidneys to concentrate that urine, causing a depletion of volume out through our urine and leading to this hemoconcentration. And so if we move on and talk about our signs and symptoms, now most of these signs and symptoms are going to be a result of our patients either being dehydrated or hypernatremic from that hemoconcentration due to that volume loss. So here we're going to see things like polyuria and polydipsia. And if you see this in alert patients, they can consume as much as 5 to 20 liters per day of fluid. If our fluids are not replaced, we're going to see signs of hypovolemia. And these are going to be those classic signs: hypotension, decreased skin turgor, dry mucous membranes, tachycardia. You'll see low CVP, pulmonary artery pressures, and a low SVO2. You'll also see hyperosmolality and hypernatremia. And this is going to be the result of the hypovolemia and having that concentrated blood and really that concentration of serum sodium from all of that water lost into the urine. You also could see mental status changes. And this could be either due to the hyperosmolality and the hypernatremia or to dehydration of our brain cells. And this we're going to see manifest in that confusion, that irritability, or possibly even seizures. So now that we know what we would expect to see, let's talk a little bit about how we diagnose these patients. The first thing we're going to be looking for is a negative fluid balance. And especially early on in DI, and one of these early signs is going to be if we have greater than 300 milliliters per hour of urine output. That as you see this high output of urine and you see it consistently without really a response to any fluids that you've given, that this can be a key indicator that your patient is going into DI. We're also going to want to check our UA. You want to see, do we have clear, dilute, colorless urine? Is the specific gravity less than 1.005, telling you that it's really dilute? Is that osmolality less than 300? Again, another sign that you have very dilute urine. This is going to be a sign of that massive volume loss coming out through the urine. You're also going to want to check your serum labs. Here you want to see if your osmolality is greater than 295, telling you have really concentrated blood, as well as checking our sodium to see if our sodium is above 155, again, a sign of that hyperosmolality and hypernatremia. You're also going to see an increase in your BUN and creatinine, again, more signs that we have volume depletion. But really when we're looking at our serum osmolality as well as our urine osmolality being less than 300, if we have both of these going on, this is usually a pretty telltale sign that your patient is in DI. If you have very concentrated blood and very dilute urine, and this process is continuing, and your osmolality in your blood is rising, and the osmolality in your urine is lowering or staying very low, this should really have you thinking DI. Now from here, if we want to differentiate between our neurogenic and our nephrogenic DI, we can perform two different tests. We can do a water restriction test or a vasopressin test. And so for the water restriction test, we're going to do just that. We're going to restrict the water that we're providing to our patients. And in doing that, we should see urine osmolality increase. If we see it increase to greater than 600, then this actually tells us that this isn't DI. The other test we can do is the vasopressin test. So once again, we don't want to give them fluids and we want to record their output at baseline. And then from there, we're going to either give them pitressin, which is ADH, or we're going to give them desmopressin, which is DDAVP. And we're going to want to measure the urine output at 30 minutes, 60 minutes, 90 minutes, and 120 minutes. If we see the urine output decrease and the urine osmolality is increasing by more than 50%, we know that this is a neurogenic DI. If they have little or no response to the administration of either of these, then this is going to tell us that this is nephrogenic. Alright, so we've got all this information in hand. We suspect that our patient is in DI of some sort. And so now we want to know, what are we going to do to treat these patients? So obviously, first and foremost, we want to identify and correct whatever the underlying cause is. Along with that, we also want to restore the normal fluid volume, osmolality, and electrolyte imbalance. And so things are really going to revolve around two main forms of treatment. First is going to be our fluid volume replacement. And second is going to be SIADH administration. So first and foremost, we need to replace the volume that has been lost. And to do this, we want to do this using a hypotonic solution. And so this is either going to be our D5 water or our half NS. And the reason for this is, one, we need to replace that volume quickly, especially if they're hypotensive. And we may need to give them a good amount of volume of fluids to replace that volume loss that they've had. But our patient's sodium at this point is going to be really high. And so we don't want to be using our normal saline fluids where we're going to be giving them even more sodium. Now, you probably know typically in our patients with head injuries that we normally avoid fluids containing dextrose, because very quickly that dextrose is metabolized and we pretty much are giving them pure water. And so in the case of patients who have a normal fluid balance, this is going to cause that water to eventually leave the vascular system, and we get concerned for this going into the brain and causing increase in cerebral edema and ICPs. But in the case here with this initial treatment in DI, these patients are very volume depleted, and so we just need to get them that volume without the added sodium. So along with that, though, it is going to be important that we're carefully monitoring our patient's sodium, because we don't want to have that rapid reduction of our sodium level. Really, we want to be shooting to drop this by about 0.5 an hour with no more than 12 over the course of a day. So now, along with this initial treatment, we also want to be replacing the free water deficit that our patients have. Now, typically what we'll do with this is we'll match our urine output on a 1-to-1 basis with our fluid replacement. So if they put out 400 in an hour, we're going to give back 400 in volume. But we can also use a free water calculation to determine what our patient's free water deficit is. To do that, we take 0.6 times our patient's weight in kilograms times our sodium divided by 140, all of this minus 1. So this is a calculation you can do to get a pretty good estimation of your patient's free water deficit, really based on what their sodium level is and their weight. And we also assume that their body is 60% water for this calculation. So these are both two really good approaches, and probably initially to do that free water calculation to determine where their volume loss is to be able to get them back up to where they should be, and then from there replacing on a 1-to-1 basis that urine output. And so obviously with this, we're going to be frequently monitoring their neurostatus and their electrolytes to make sure that everything is going appropriately with our treatment. Now for the second form of treatment, this is where we're going to talk about our ADH administration. And this is basically giving them that exogenous ADH. And so here we really have two choices. We can give them the vasopressin, which is also known as pitressin, or we can give them desmopressin, also known as DDAVP. And so really vasopressin is not our preferred treatment. The reason for this is, as we talked about earlier, it has that powerful vasoconstriction effect, as well as it can increase that platelet aggregation, both of which can cause problems in our patients, especially our patients who have a volume depletion. So typically we're not going to use this treatment, although if you don't have DDAVP available to you, you can use this. And so then really our agent of choice that we want to use is DDAVP. And the reason for this is it really has limited vasopressor effects. And oftentimes we'll give this to our patients IV every 12 hours, although it can also be given through a nasal spray 3 times a day. And we want to do this until our therapeutic goals have been achieved. So we've got normal urine output, a normal urine specific gravity, normal serum sodium, as well as a normal serum osmolality. But the really important thing to know with our ADH administration is this isn't really going to be very effective in nephrogenic DI. And again, that's because we have the ADH available, it's just our kidneys aren't able to respond to it. And so giving them more, while it can be treatment that we do sometimes, it's really not going to be too effective. All right, so that was a pretty good overview of diabetes insipidus. Like I said, we've got a couple different causes for this, but just know that our main point with DI is this is a result of either insufficient or an insensitivity to ADH. Therefore, our body is not able to concentrate urine, and we see massive volume loss in the form of our urine output. Therefore, the signs and symptoms that we're going to see are really going to be a result of that volume depletion, and our treatment is going to be primarily aimed at replacing that volume and, if appropriate, giving them the ADH that they need. All right, so let's go ahead and move on to our syndrome of inappropriate antidiuretic hormone secretion, which is what we often refer to as SIADH. And as you can probably figure out in the case of SIADH, here we're going to have this excessive release of antidiuretic hormone without any regard to our plasma osmolality or our fluid volume status. And so what's happening here is our normal mechanisms that control the ADH secretion are failing, and this leads to this excessive ADH release. And ultimately, this is going to lead to an impaired ability to excrete water via urine, and ultimately a profound hyponatremia. And to really summarize this, basically SIADH is going to be a syndrome of water intoxication. So let's talk about what some of our causes are for SIADH. And it's really important to know that there are many causes for this. It can be caused by things like malignancies, because there's many of these that can actually produce ADH themselves, one of the most common being our oat cell carcinoma of the lung. This can also come as a result of certain pulmonary conditions. Positive pressure ventilation can do this. Asthma, pneumonia, COPD, acute respiratory failure, or even TB can all be contributors to this release of ADH. And if you think about it, these are things that you're going to see pretty common in the ICU in your patients. This can also be as a result of some sort of CNS disorders. So again, think head trauma, tumors, CVAs, infections, or even Guillain-Barré syndrome can do this as well. Also, certain drugs can cause this. So common ones are like chlorpropamide or our thiazide diuretics. Also, opiates and nicotine can cause this, and tricyclic antidepressants. And then finally, a couple other causes for SIADH can be things like AIDS or even surgery as a result of the stress response, as well as the opioid analgesics that are given. And so there are many of these causes that can really potentially lead your patient into SIADH. And so to quickly just review the patho of kind of what's happening here, so we have this excessive amount of ADH, and this is going to lead to this excessive amount of water uptake. Again, this is going to be happening in the kidneys. And because of all of this water intake, we're going to see this hemodilution, hypervolemia, and as a result of this hypervolemia, you're going to see this profound hyponatremia. So think about, because we have all of this fluid still in our body and in our vasculature, this is going to dilute this sodium in our blood. So now let's move on and talk about the signs and symptoms that we're going to see in our patients with SIADH. And the symptoms that we're going to see are going to depend on the progression of this SIADH. So we're going to have these mild or early signs, as well as these severe or late signs. And so what'll help you remember these signs and symptoms of whether they're going to be mild or early or severe or late. In the mild and early, that this is mostly due to this hyponatremia. So we're going to think about these signs and symptoms we'd see as a result of that. So obviously we're going to have our decreased urine output. Our patients can have nausea or vomiting, possibly headache. They can have dulled sensorium. You'll see that hypertension from that hypervolemia. They can have muscle weakness or cramps. Also, because of this fluid volume overload, we could hear crackles. Patients could have trouble breathing. Also fatigued. And you'll see an elevation in your CVP and pulmonary artery pressures, again as a result of that excessive fluid. Now, as we move on and talk about these severe or late signs and symptoms, that these are going to be a result of CNS involvement, mostly due to the brain edema. So here, because of all of this volume that we have, that volume is going to be shifting out of the vasculature over time, and this can lead to an increase in our cerebral edema, causing these CNS symptoms. So this is where you're going to see things like confusion, possibly hostility, could see hypothermia, possibly respiratory impairment, convulsions, or even coma. So obviously the longer that this goes on, this can have some very serious consequences for our patients. And so it's going to be very important that we're able to recognize this early on in order to be able to intervene and prevent things from progressing to this more severe late stage. And so the question then becomes, in order to prevent this from happening, how do we even diagnose this? And really, our labs are going to give us these hallmark signs for SIADH. So we'll be taking a look at our UA, and do we have that dark concentrated blood? Is our specific gravity greater than 1.025, or the osmolality greater than 500? So again, indications that we have very concentrated urine. We're also going to look at our serum osmolality. And is that less than 275, telling us we have dilute blood? Along with that, we're going to be looking at our sodium level. And do we have that profound hyponatremia where we're less than 130? You'll also expect to see a low BUN, creatinine, and albumin, which are all going to be signs of hemodilution. And then finally, we can do what we call a water load test. And this is essentially where we give them a fluid challenge, and if they eliminate less than 50% of that in urine, that this can also be diagnostic for SIADH. So now here again, we have our patient. We believe that they are in SIADH. So what are we going to do for our treatment? And so here with our treatment, our principal management of these patients is going to depend on that severity and the duration of the hyponatremia that they have. Like I said, really, early recognition is key in this to preventing that life-threatening complication. So now when we talk about our treatment here, we're generally going to be focusing on doing three main things. First is a fluid restriction and treating the hyponatremia. We also want to be replenishing our sodium deficit. And in some cases, we want to inhibit the action of antidiuretic hormone. So here we want to be restricting their fluids to around 800 to 1,000 milliliters per day. Now, if our patient's sodium is in the range of 125 to 135, typically this fluid restriction alone will allow the sodium levels to correct. If this fluid restriction alone is not enough to correct this sodium, then this is where we might consider giving something like demoxycycline. And what this is going to do is this is going to inhibit ADH on those renal tubules, and this is going to allow for the excretion of water. Now, if we have positive neuro changes and our sodium is less than 125, then this is when we're going to want to consider giving 3% saline and possibly Lasix to aid in the excretion of water. So here we're having these serious effects of our hyponatremia as well as this volume overload, so we really need to get that sodium back up as well as we really need to get this fluid off of them. And Lasix, as we all know, is pretty good at doing that. And the last thing that's going to be really important in these patients is we want to be assessing their cardiovascular and their respiratory systems. And this is going to be a result of all of that volume overload, that this can really strain our body system, and this may actually even lead our patients into heart failure. All right, so that pretty much covers our SIADH. Important thing to remember with this is as a result of an excessive release of antidiuretic hormone. Our body is going to be really concentrating that urine, and we're going to end up with this massive volume overload and this profound hyponatremia, which are going to lead to these early and late signs and symptoms that we're going to see in our patients. And the treatment that we give, well, early recognition is really truly key in preventing these life-threatening complications. The treatment that we're going to be providing to them is restricting their fluids, replacing that profound hyponatremia, and possibly even stopping the action of the ADH. All right, so we covered quite a bit of information here between DI and SIADH. Important things to know, these are both disorders relating to antidiuretic hormone. One, in the case of DI, happens to be from not having the effects of ADH, as opposed to SIADH, where we have too much of the ADH and too much of its effect, leading to the problems that we see. Two very different disorders, but both dealing with the same hormone. Now, both of these are the two most common ADH disorders that we are going to see in the ICU, but depending where you work, they're really both not very common to see, but in some areas, DI is something that you might come across quite a bit. So it is important that you know these, because there is a good chance that you are going to come across this in the care that you provide for your patients. And it helps to have this good understanding of what's happening, what you're looking for, and how you would expect them to be treated. All right, and so with that said, I do want to thank you guys so much for watching. I really hope you enjoyed this lesson. I hope that you guys found it useful and had some good information in there. If you did, please leave us a like below, as well as leave us a comment and let us know what you thought of the video. It really goes a long way to support our channel. Coming up in our next lesson is going to be the last lesson in this series, in which we're going to take a look at the difference between our thyroid storm and our myxedema coma. So make sure you guys subscribe and stay tuned for that. And in the meantime, make sure and check out the last series of lessons that we did, in which we did a good review of heart failure. All right, thank you guys so much. You guys have a wonderful day.